Thank you everyone for joining today for our webinar. Excited to jump into today's topic and really kick off a series of webinars really directed towards providers such as yourself. To kick things off, we're going to start high level, introduction to whole body MRI. We're going to dive into some of the benefits of our screening. And you're going to hear from some pretty great people today. So we're hosted today by, we got Dr. Dan Durand, who's our Chief Medical Officer. He's our President of Prenuvo Medical Group. We also have Dr. Sean London, who is our Interim Vice President of U.S. Radiology Practice. And then we have myself, Eric Chafe. I am the Head of Sales. And my time for speaking is done because I want you to hear from these two gentlemen moving forward. So at that point, I'm going to throw it over to Dr. Dan Durand. Take it away.
Thank you very much, Eric. So we're here to discuss Prenuvo today. What is Prenuvo? What are we focused on? What is whole body MRI? And really, what we're designed to do at Prenuvo is to flip the healthcare system from its current reactive posture to a more proactive posture. In other words, we're trying to see things before they happen. We're trying to see diseases at its earliest stages. And as healthcare providers, we know there are a variety of different ways that one can go about doing this. But historically, the physical exam, which is part of the annual checkup, has been significantly limited in what it can detect. And so by the time you can see something on the outside of somebody's body or palpate them or otherwise divine what's going on inside, all too often that pathology has progressed too far and it's too late to meaningfully intervene for that patient. So by using the world's most powerful modality, Prenuvo is trying to flip the script and find disease well before it impacts patients, well before it manifests symptoms. How do we go about doing this? I'm going to show you some pictures that get into the nitty-gritty of what our centers look like and what our scanners look like. But at the basic level, we are trying to extract as much information as we can from the patient in the most compassionate, least invasive, and least harmful way possible. So MRI is great for that because there is no ionizing radiation in MRI. We're able to image the entire body using a variety of different sequences, different ways of looking with the MRI machine into the body to give ourselves and our radiologists a large amount of data. About 1.3 billion data points are obtained from every single patient that we image with our whole body protocol. The other thing that we don't do is we don't use contrast. And the reason we don't use contrast is we foresee this, like the physical exam, as being an annual event in patients' lives. And so we don't want to introduce anything potentially harmful to them, even if it's unlikely to induce harm in any one patient. Contrast is absolutely necessary for diagnostic exams when it's indicated, but putting a heavy metal into your body that could potentially have other downstream sequelae or potentially cause an allergic reaction, we don't believe it's necessary in the screening context. So we're able to do what we do not only without contrast, without injecting into the veins, but we don't actually have to enter the veins. So there's not even a pinprick. We don't have to start an IV to be able to inject the patient in the center. So this allows us to simply place the patient in the scanner, obtain a great deal of information from the patient, not cause any near-term harm or any long-term harm from radiation, and not cause any discomfort. So really, the idea is to get this information and offer insights and to do it in the most pleasurable way for the patients that they want to come back and get this done every year. Prenuvo is the largest provider of whole body MRI in the world. We have 17 centers currently. Our practice has greater than 15 years experience. By virtue of the fact that we only focus on whole body MRI and we do it every business day of the year, and we've been doing it one way or the other, either as Prenuvo or as our predecessor clinic in Vancouver for some 15 years, we are the most experienced at doing this in the world. We think we've done at least 10 times as many scans as any other organization. And like everything else in healthcare, you get good at what you do often. We also have the largest data set to help guide our decisions in our everyday medical practice. So looking at outcomes and ways we classify things, what happened to a case that looked like this one before, we're able to do that in a bigger and better way than others are because we have more data. But beyond that, when it comes to developing the next generation of AI models, this is something that in the coming years will be powering the care that's delivered at Prenuvo because data is power, and with more data, you can deliver more accurate, and more consistent services. The other thing that's unique about Prenuvo versus others doing this is we're not only very focused on it, but we own the entire value chain, because it's our belief that you need to be precise and accurate in delivering whole body MRI. And the precision comes from doing it the same way every time, everywhere you do it. And the accuracy comes from doing it extremely well with the right people. So along the precision side, we have built all of our scanners to spec. We have different suppliers, but we have one type of scanner. We do our scans with the same types of coils, according to the same exact protocols every single day. We put phantoms in, so calibration equipment in the every scanner every day. We do it the same way. We own the equipment, we own the centers. All the staff that are operating the equipment report up to us. They're our employees. And in this way, we're able to do a very, very consistent whole body MRI across 2 different countries currently, and eventually across the globe. The last piece around the accuracy, that comes from both getting really high quality images, which again results from that sort of consistent and highly precise way of obtaining the images. But getting the accuracy relates to getting the best radiologists who have the most experience and the most relevant experience to read the images and to do it in a very specific way. So we have recruited radiologists with relevant expertise. We have tested them before they join. We have rigorous quality controls within the practice. And then every single case is read according to a very structured checklist, kind of like a home inspection list for the entire human body. So we have more structure in our reporting and more routine that our radiologists are sort of forced to go through in a good way that helps guarantee the accuracy and quality of every scan that's read at Prenuvo. This is what our centers look like. So I mentioned before, we're trying to obtain a lot of information. We have these lofty goals of transforming medicine, but at the end of the day, the patient needs to feel that the experience is entirely built around them as a unique individual. So we've done a lot of study on the types of colors, the types of atmosphere we want to have in our clinics, and ultimately we settled on this sort of, I would say, meta-spa-like arrangement where patients come in, there's focus on them uniquely as individuals because we don't have a lot of people in our waiting rooms. We have comfortable places for them to sit. We have a relaxing atmosphere. It doesn't feel like the rest of healthcare. It doesn't have that cold, sterile, kind of mass-produced feel that a lot of healthcare does. It's a warm, smaller, inviting space. It's actually a series of small spaces they'll be in. Pretty quickly after they're in this space, they get brought to the back where they'll have their own individual waiting room where they get ready for the scan, and then they'll go and get the scan. Well, they'll have a one-on-one, relationship with their technologist while that's going on, and then they'll go back to their waiting room, and eventually they can come back out to the lobby, have a snack now that they're done with their scan, and leave. And there's a reason where, a lot of people, they don't understand this. Why are we trying to make this so retail, so spa-like? And again, it comes back to, we believe that like other screening methods, this has the potential to transform lives, to save lives. And we're very aware, and I personally, having run a health system prior to my job with Prenuvo and having run many population health programs at that system, the real problem with screening right now isn't that there aren't ways to screen, it's that people don't always want to do it. There's a mixture of anxiety and apprehension, and there's also some discomfort associated with many types of screening. So while Prenuvo is not trying to replace any screening, and I'll say that again, Prenuvo is not trying to replace any existing USPTF recommended screening. We think people should still get their mammogram, their colonoscopy, if it's indicated, their chest CT for lung cancer, and other things. We augment that, we don't replace it. However, as we go forward into the future and build this screening platform off of whole body MRI, we want people to like it. We want people to enjoy their experience. We want people to feel in control in a way they haven't in healthcare before. And this is one of the things that the Prenuvo brand is most associated with, most positively associated with, is this sort of comforting, warming environment that people come into, the lack of discomfort and pain during the procedure, and the sense of agency and control that each individual patient has when they're in our care. And this goes, so when we go in the front of the house, I showed that to you, and this is the back of the house. It does look a little more healthcare-like. At this point, we're in zone 4, right? And this picture is taken from a place that it's safe to take the picture from. But this is what it looks like for the patient. Calming environment, very focused on the scanner, not a lot of other stuff in the room. Inside of that scanner, as you come toward the back of it, there's a set of mirrors, and there's actually a transparent wall behind the scanner, behind which, outside of zone 4, is a TV, again, all of which is in an MRI safe construction, arrangement. So there's no danger to the patient from the TV being there. But the light from the TV scan can get into that room. It's a large screen, and it can get reflected in the mirrors. So the patient, as they go back into the scanner, and I've done this myself, you feel the scanner kind of open around you as you get toward the back, and you're able to sit there and watch various different streaming services. You can watch TV. You can also just listen to music. We can put up pictures and calming music. We can do all sorts of things depending on what the patient likes. But it's a unique arrangement that is very consumer forward, right? Very consumer centric. So this is what it looks like in the back of the house. These are the scanners we have, and that's what the experience feels like during the scan. The scan itself takes about 45 minutes these days. If nothing goes wrong, the patient doesn't move, etc., we're usually able to get all the images within 45 minutes. Almost always we can get all the images within an hour. And for those that know a bit about whole body MRI, this is truly an achievement to get the scan times down, to such a reasonable amount. Obviously, we'd like to get them down even smaller. Like, our goal is to get this to be as seamless and easy for patients as possible, but we need to make sure we get enough data for it to also be meaningful. So those clinics that I showed you, that kind of outside, front of the house feel, and then anywhere from 1 to 5 magnets in the back, the way we showed you, along with all the patient changing rooms and things like that we didn't show you, those comprise our clinics. There are 17 independently located locations throughout the United States today. We're also expanding internationally quite a bit over the next 2 years as well. Here you see existing clinics shown in dark dots, and then planned openings in brighter or colored dots. And this is the most exciting part about working for this company, or one of the most exciting parts. It's not just the way we're transforming healthcare, but we're kind of transforming the way patients experience healthcare in every single one of these geographies as we go across the country. And the response from patients and providers as we enter each market is really phenomenal. Every time we have one of these blue or purple or green dots, and every time we put a new one on the calendar, we open up a new booking site, we have an incredible amount of demand that precedes us in the market. And every time we open, we're full from day one. And that's a great feeling, and it kind of just lets you know how much this is felt to be needed by patients and physicians throughout healthcare. So today we're going to talk about the benefits of whole body MRI. We're going to talk broadly about it. And I mentioned before, you can think of it as a replacement, a very powerful replacement for certain aspects of the physical exam, the non-external aspects. It's a new thing that hasn't existed before in the way that we are applying it. And we'll talk today about what some of the benefits are to patients and primary care doctors when we get these scans and when patients receive their results. So I've already covered a bit of this, but why screen with whole body MRI versus other things? So accepting the idea that you want to look on the inside of the body if you can, just as we look always on the outside of the body during every physical exam that's ever occurred. Of course, you'd want to look inside the body if you could. I mean, that's sort of a given with our approach. And you have a couple different options if you're going to do that. Broadly speaking, you have the different modalities. So you can use plain film, like x-rays, right, and get a bunch of different two-dimensional pictures. You can use a CT scan and get really high-resolution images that are not great contrast between different types of soft tissue, but very high resolution, but also usually requires a significant amount of contrast and a significant amount of radiation, those being the downsides to CT. Ultrasound, no radiation there, but very operator dependent. Images, aren't super meaningful to patients and non-radiologist clinicians. It's kind of, I can certainly understand them, but it's sort of like looking at sonar or some sort of other thing. It doesn't really look to most people like the part of the body that they think they're looking at. Then there's PET scans and other types of nuclear medicine, which have their place in molecular imaging, but aren't used really in screening, again, because of not just the high radiation, but also the very high cost of preparing those reagents. And finally, we have MRI, which 30 or 40 years ago was extremely costly, but the costs have come down quite a bit, and the technology has improved quite a bit. And this lets us screen and for many, many different conditions, almost any type of medical condition that manifests symptoms outside of psychological conditions has some sort of MRI correlate. It isn't always the case that MRI is the exact best way to diagnose that, but across the various different conditions that can impact humans, asymptomatic and symptomatic conditions, MRI is by far the most powerful modality that can catch the most things. And that's because you can use it in so many clever different ways. So we see here there's examples of different sequences that you can use in MRI. And the top are these anatomic sequences. These are things that are looking at the structure, and when the structure is asymmetrically abnormal as it is in some of these images, it kind of quickly focuses you on the pathology that's present. So anatomic would be things like your T1 sequence, your T2 sequence, and your different flavors of that. Then there are your vascular and flow maps, so you can actually see the flow of blood. And yes, we can do this. People are always surprised. We can do this without injecting anything into the blood. We can selectively label in a transient and safe way molecules in the bloodstream, and then we can detect the signal as it decays. So we're able to both put information and energy into the body with the MRI scanner and sort of receive the signal when it comes out, and we can use that to kind of inject signal into things like the CSF or the veins or the arteries, and we can obtain really great vascular flow maps and even fluid flow maps of other fluid compartments in the body. And lastly, there are these very advanced sequences, physiological sequences. We can measure the diffusion of water, so the motion of water between the tissues and within tissues is called diffusion-weighted imaging. And it was first focused on and became famous for diagnosing stroke, but actually you can diagnose almost any hypercellular state or state of cytotoxic edema with diffusion-weighted imaging. So it's also very, very good, we've learned, for diagnosing and identifying cancer and inflammation. So this is a very important part of the Prenuvo scan, is the whole body diffusion-weighted sequence that I'll talk about in a bit. Other things you can do with MRI, you can actually map out all the fibers in the brain. You can do diffusion tensor imaging. This isn't currently part of our protocol, but you can. And then you can use it to measure regional blood flow, not just map out the vessels, but look at things like blood flow to different regions of the brain. And so famously, a lot of studies are done with what they call fMRI or functional MRI, usually using bold or arterial spin labeling to look at the different regions of the brain that are activated different types of thinking tasks or other tests that they do to experimental subjects. So our standard screening protocol looks as follows at Prenuvo. And I'm not going to, this isn't a radiology lecture, we are going to do some cases, but I'm not going to kind of drag you through all the different physics of each of these weightings. But I think the impression we're supposed to give here, right, is every one of these single static images that you see in this collage of our standard protocol is actually an entire series of images. So that sagittal sequence in the upper left, that actually isn't just one image, right? We're going all the way through the patient's body in that plane, that part of the body in the plane. And as you can see, in many of the planes we're doing the entire body, and some of the planes we're focusing at higher resolution with a lower field of view on things like the prostate or the brain or the spine or the circle of Willis. And in doing it this way, we get an incredible amount of data. This is where we get the 1.3 billion data points. That's all the data that goes into constructing all these images. Each of these series has hundreds of images, and collectively they have like 2,000 images total. Every single one of these 2,000 images gets reviewed by the radiologist as they kind of formulate their opinion of the case. And we mention more than once here the diffusion-weighted protocol because it is so unique to Prenuvo and it is so important for what we do. There is a physiologic background of things that will demonstrate restricted diffusion. And you see some of that here on this scan. The spinal cord, the brain are high restricted diffusion relative to the rest of the body. The spleen is, and you kind of get a sense that different organs and areas have intermediate signal. If something is abnormal coming across as very high restricted diffusion, then that is going to be something we look at closer both on our other sequences, and more likely than not, it will then get a follow-up imaging of some sort, usually an MRI, honestly, because again, MRI, higher resolution MRI with contrast is often the next step when we find something that is a suspicious lesion. This way that we do this is the reason why we use 1.5 Tesla versus 3. So it's kind of easy to sort of lapse into the idea that, hey, higher numbers are better. I want more slices in my CT scans. I want more higher frequency on my ultrasound. I want higher field strength in my MRI. And actually, none of those things are necessarily true for either MRI, CT, or ultrasound. Depending on what you're doing, you might want higher or lower numbers for some of these things. So for Tesla, it gets you on the MRI scanner, it can help you do shorter scans for certain things and higher resolution for certain things. But it also introduces more artifacts when you're doing these advanced sequences that I've referenced. And diffusion in particular gets very finicky and hard to do. And because we're looking for potentially very small things that are like a centimeter, around that. The most interesting stuff to us on diffusion is the things that are lighting up. They're high diffusion, but they're small, right? So an artifact, if you think about it, can really either obscure that or it can create a false positive. And so it's really important to have a very clean signal-to-noise ratio within your diffusion-weighted imaging. And this is something we've found, right? And again, I'm not trying to say that we know the entire universe, but the reason the Prenuvo fleet is built on 1.5 Tesla scanners, one of the big reasons is that we haven't found any other way to get really great whole-body diffusion imaging. And part of the reason for that is that the field strength determines how quickly the diffusion signal that you have to capture decays. And so under higher field strength, you actually get very quick decay of your diffusion-weighted imaging, making it harder to capture. It gives you less time to sort of optimize and capture that signal. So by using 1.5, actually slightly less strong magnets, it gives us more time to gather this signal. And this, we believe, is our most valuable sequence because it finds, again, not only cancers, but it can find areas of ischemia, inflammation, infection. And again, you'd be amazed at how much of the stuff we find in people walking off the street without symptoms. We find it's very common to find occult infections, areas of inflammation they didn't know about, and often quite important for them in the course of their disease that we were able to find that early. So now I want to get into what it is we find. We screen all the organs in the body, and depending on how you number them or label them, we think about 33 different organs that we look at. We can scan, like I said, pretty much anything can manifest as an MRI manifestation, almost anything. Honestly, not with the sequences that we use currently, but there have even been studies that have shown MRI findings in schizophrenia, which is something that really was thought to have no physical manifestation. But if you do that diffusion tensor mapping, you can actually find some information that's predictive of that. So it may be that in the long term, like literally every single condition winds up having an MRI equivalent. But in the near term, there's at least 500 conditions that do, and it's the vast majority of things that we focus on in medicine actually have some sort of MRI equivalent eventually. The idea is, can we find as many of these things as early as possible? So I'm going to just go through a bit of a laundry list here before I hand over to Sean for some specific cases. But these are the types of things we find that are very meaningful to primary care physicians, specialist physicians who ultimately wind up treating many of these things, and certainly the patients themselves. So on the neuro side, we can see regions of cortical atrophy, so brain atrophy, either diffusely, if it's more than expected for age, or if it's very localized, that could sort of like imply that there might have been a traumatic event there, either traumatic brain injury or a prior ischemic insult. Aneurysms is something we find quite a bit of. In fact, in about 2% of our patients, we'll find some kind of circle of Willis aneurysm. Only about a fourth to a fifth of those are large enough that they warrant actual intervention. But again, if you're 30 years old and you have one that is not large enough to warrant intervention, it is good to know about and follow because a subset of those will enlarge over time. And if you've known someone, a person in your life or a patient who's died from a ruptured aneurysm, these are truly some of the more tragic deaths because there really is often no knowledge of the disease or preparation. These people are simply here one day functioning, gone the next, leaving a big hole in many lives when they go. So this is something we're really proud that we can help patients get ahead of, because if this can be treated, they really should not die from that condition. We also see a fair number of both benign and malignant tumors within the CNS, and we have a reasonable following amongst academic neurosurgeons because there is a growing number of academic neurosurgeons that believe in being fairly aggressive around resecting certain types of benign tumors in the brain because they often transform and grow slowly, and the earlier you resect them, while there's morbidity associated with them, they tend to have better long-term outcomes. So this is not an area without controversy, but overall the trajectory seems to be going into being more interventionalist around things like low-grade gliomas that are growing in people's brains. And then there's degenerative white matter disease, which currently can be from a range of different things, but many practitioners and many patients appreciate knowing that it's there and also tracking it over time to see if lifestyle interventions are slowing the arrival of more and more bright spots in the white matter. There is certainly active debate there as to what the right interventions are and what all these different focal spots within white matter mean long term. But I think all of us as practitioners, we'd rather they not be there than be there, and if they're there, we'd rather figure out a way to arrest them, because in general they're felt to represent pathology that is ultimately going to lead one way or the other to neuronal or functional loss within the brain over time. And as one ages and those really become more common or become more confluent, and lead to atrophy, then the thought is it also probably contributes to dementia and other kind of higher level functions of the brain. So while this is a developing area, we think it's an important area. And it's one of those areas in medicine where you might not know the entire pathway today, but it doesn't mean you don't want to have the information personally, or you don't want your patients to have the information. On the musculoskeletal side, we see a lot of information in terms of the spine. We see a fair number of bone lesions. They're overwhelmingly they're benign, but sometimes they aren't. Sometimes they are a lymphoma or a metastasis, and sometimes that's the first time that's being discovered, and the primary isn't known yet, or we eventually find the primary, so that can be quite important. We see an awful lot of arthritis, and a lot of times, and I'll say this on my scan, like sometimes that gives you some answers, right? Because they're coming for a general screening exam, but doesn't mean they don't have any complaints or parts of their body that are bothering them or questions about that. So I found 4 separate answers that I had been seeking that I had sort of suspected but didn't have the information on until I got my Prenuvo scan, and none of those things were like the number one reason I was getting the scan, but actually all of them were like welcome information for me to have so that I know what's going on with my body. And then other forms of arthritis, for example, inflammatory arthritides, we can, sacroiliac inflammation, things like that we can see. On the cardiometabolic side, the heart is moving, so we don't get a lot of structural information about the heart currently in our scan, but we can tell if it's enlarged, and we can also tell if the aorta, the ascending aorta, is especially enlarged. So those are common things that come up. And then about 20% of our patients have fatty liver disease of some sort. In the general population in the U.S., this is thought to range up to even higher than that these days. But in our population, it's around 20%. And a smaller subset of those has moderate or severe fatty infiltration. And I think this is one of the areas that we're going to do the most good, because this is a silent epidemic or pandemic, depending on who you talk to, of fatty liver disease in society right now. It's going to lead to a lot of cirrhosis, a lot of mortality and morbidity. And yeah, you could say, like, listen, these people simply need to exercise more and perhaps eat differently. And, we can all say that, but when you have a scan and you can show with precision to this patient, hey, your body is undergoing this consequence today, and, this is real for you. This isn't theoretical. And if you don't take these steps, then you could very well wind up with cirrhosis. People behave differently. And we've had people come in and have this picked up and then go on a very different path in their health, either sometimes taking GLP-1s or sometimes just pursuing diet and exercise. We have a number of cases where we followed the patients, and this diagnosis has made a big difference in their trajectory. All right, some other systems. Pulmonary, we can see pleural effusions, we can see pneumonias. Again, in the oncologic category, which will come last, we can also see lung nodules that restrict diffusion, or lymph nodes that restrict diffusion that can wind up being cancer, but they can also wind up being other things like sarcoidosis. Either way, these are wins for the patient, especially if they didn't know about them before. On the digestive side, we see stone disease of all sorts, so we'll see gallstones would be included in that. Again, it usually doesn't mean that they need their gallbladder out at that point, but it may explain pain that they've had, or it may give them a reason to address that before they wind up having gallbladder issues. We see esophagitis, and then diverticulitis, and diverticulosis in many people, as you'd expect. And diverticulitis, like low-grade, in a fair number as well. This is one of the, I think, surprising things, is the number of low-grade infections and areas of inflammation that we find with the scan, which turn out to be associated with some low-grade symptoms when the patient reflects on it, and then is associated with relief when they get treated for it. And then other infectious inflammatory conditions going along with that, lymphadenitis, bladder, acute cystitis, sometimes low-grade, pyelonephritis and things like that. Just, again, you would be surprised over the course of tens of thousands of cases the level of severity of some infections that we found, pneumonias and diverticulitis in particular, in people walking around just sort of grinning and bearing it and going about their business. Some additional things on the women's health side, we can find fibroids, endometriosis, various different types of breast disease, including ruptured implants, which we see a significant percentage of the time, actually, and ovarian cysts and cystic lesions. Also, not shown here, but there's been some well-documented cases of kind of influencer types who have shared their experience. We can often find things going on like fibroids or septae within the uterus that explain, years or even decades of issues people have had with fertility. And so that's an increasing thing that we're giving people insight is some of the sort of traditional women's health issues like pelvic pain and adenomyosis and endometriosis, but also these more contemporary issues of just the fertility Again, another silent epidemic, or becoming less silent epidemic. Many people in this country with fertility issues, many of them undiagnosed with underlying conditions that are driving those fertility issues. And the usual fertility approach, in many of the clinics is more therapeutically oriented than diagnostically oriented. So it's not unusual for us to be able to help people out or offer them insight into what's going on because they haven't had a really in-depth exam of the uterus, the ovaries, etc. prior to coming to us. On the men's health side, we get good imaging of both the prostate and the testes. Prostate MRI has really come along, has been shown to decrease the number of biopsies, has been shown to be very accurate at targeting biopsies, and is increasingly being used as an additional screening modality in men. And then on the urinary side, we can see any sort of diverticulum or malformation or abnormality of the genitourinary system. So we can see if people are missing kidneys or if they have low-lying kidneys, if they have chronic hydronephrosis, if they have diverticuli in their bladder, all those sorts of things. All right, and then we can see a wide variety of other things like that don't necessarily relate to a specific organ, right? Like multi-organ diseases that involve cysts or hemangiomas in many organs, hernias, autoimmune demyelination, or just general autoimmune conditions that may have many manifestations. And then I mentioned a lot of congenital abnormalities. Again, like having one kidney is not necessarily something people are aware of, but they become aware of it when they lose the function of that one kidney or if they, have a trauma to that one side. And it's not a bad thing to know about if you have less than one of, less than two of an organ that is normally paired, whether it's like an adrenal or a kidney. I think it's a good thing to know about. And it's just, it's people always appreciate learning that as part of the, as part of their Prenuvo experience. All right, lastly, we are evolving the way we report at Prenuvo. We have a highly structured checklist that all of our radiologists work their way through. And at the end of that, we use something called the ONCO-RADS system that basically expresses the most worrisome lesion that the patient has from an oncologic perspective is ranked a 1, 2, 3, 4, or 5. And essentially the 1s and 2s are either like there isn't a lesion or it's certainly benign based on the MRI imaging characteristics. Those don't require specific follow-up to that lesion. They can come back for regular screening. If they have a 3, okay, like this is like an intermediate lesion, this is the one that in a low-risk population probably needs, either a non-contrast scan to check up on it in a shorter interval like 6 months, or to go just immediate to a full contrast exam to characterize that lesion and put it to rest. And then once that's done on subsequent exams, that same lesion would then likely be characterized as a 2 unless it's changed in its appearance because we have other imaging that shows what it is. But in a high-risk patient, a 3 would be considered like a little, so let's say a patient was being followed for prior cancer. If they have a new intermediate lesion, it kind of gets treated a little differently and kind of falls more in that higher risk bucket that goes more urgently for further evaluation. And then there are the ONCO-RADS 4s or 5s, and these are like either, moderate and highly likely to be cancer. Regardless of who you're finding them in, they're getting worked up. And they don't always wind up being cancer. In our biopsies, in our largest biopsy series, which we recently published, a little more than half of the biopsies that were initiated by a Prenuvo MRI wound up being cancer. So that's actually a very high true positive rate if you know what biopsy positivity rates typically look like. So that's quite good. But even when it's not cancer, a lot of times, it winds up being an infection or a non-cancerous thing that still needs to come out because it's like pushing on the brain or some other important structure. So it's the 4s and 5s are things that really do need to be looked at, and the next test for them is, I would say, always imaging. I mean, I haven't seen many or maybe any Prenuvo scans that go directly to biopsy. We screen, we find something, we tell the patient and or their doctor, they get another imaging test, and then typically, if that one continues to be worrisome, they proceed to biopsy. When the patient gets these results back, they get a physician's report, that really detailed checklist that the radiologist went through gets translated into 2 things. One, there's a PDF of the radiologist's actual report that's embedded into the patient's app that they can immediately read, but it also gets translated into something that's more like a patient-facing report that takes the patient through all their organ systems. There are key images the radiologist makes that are embedded in the app, and the patient can sort of localize them by organ system and find and see all their key images. and it gives them the results in more of like a layperson accessible language. And this is one of the things patients really love is, unlike the usual imaging experience where you kind of go in, you get imaged, you wait for the results, they go to your doctor first, they kind of go into the PACS system. More recently, like people might have a portal in their patient portal where they can, if they know where to click, they can find that and look at it. But patients generally kind of feel like their images are remote from them, and there are lots of experts between them and their data. And so one of the, again, the big focuses of Prenuvo, just culturally, like we're a patient and doctor founded company, is we put the information and the actual images directly into the patient's hands, like at the same time that they like, or very shortly after they go into the referring physician's hands. So if they're direct to consumer, they'll just get this, right? And then a nurse practitioner from Prenuvo, if they want, will walk them through the results. If they're referred to us by a doctor, then if there's an acute finding, the doctor will get a heads up. They'll get released to the doctor a little bit before the patient. But again, in compliance with federal information blocking rules and also just the culture of our company, the patients are getting this pretty quickly. They're getting the scans usually read within a week or so of when they're done. The patients get all the images, they can scroll through them, they get a report, and then they also get that consultation from a nurse practitioner if they would like, and the majority of patients do choose to get that, so that a human walks them through this. So this is the last piece, right? I said before, we're extracting a lot of information, we're trying to do it compassionately, without pain, keep it positive for the patient. But the last piece of that is really get that information back in their hands, like the insights that came out of the information. And even just the raw data, to assure them like they own their raw data, it's still here for them. It'll help us, that raw data could help their current healthcare providers, give them care. It will also help us in the future as we do their next Prenuvo exam, see how their body is changing over time. And then all this data, as we come up in the future with different types of AI-driven insights, the patients will benefit from that, because that they have their data in our system, and those insights and algorithms can be directed at their future scans and probably most of their current and past scans as well. All right, I'm going to hand off to our Vice President of Radiology in the United States, Sean London, for some cases.
Thank you, Dan. That was great. So here I wanted to take this opportunity to go through cases with everybody to illustrate the various types of findings and disease processes that we can actually see with our screening exam, which is quite comprehensive. So here's a first case showing a 42-year-old male with a past medical history of ulcerative colitis and constant abdominal pain. The image here is showing the diffusion weighted imaging, which Dan had talked about earlier, showing the free diffusion of water molecules within our tissues. And what this really highlights is abnormal hypercellular tissue masses and areas of inflammation. And what we see here, this is a coronal image, a coronal DWI image. So the red circle highlighting the abnormality is actually on the patient's left side in the left axillary region. And what this is showing is abnormally enlarged lymph nodes, a conglomerate of abnormal lymph nodes that actually look like a mass. And this type of appearance, while we don't have the tissue diagnosis at that time, this is very concerning for lymphoma or some other type of lymphoproliferative disorder, which would require further evaluation. Here we have a 39-year-old female who presented to us for screening, asymptomatic. And what I wanted to illustrate with this case was how what Dan was highlighting earlier was how people can walk around with low-grade inflammation, but they're not quite sick enough to go seek any other medical therapy at that time. And here what we see is the red circle is over the top image and the bottom image. It's in the right lung, and it's highlighting a focal opacity within the mid portion of the right lung. And this has the appearance almost certainly reflecting an infectious inflammatory process, essentially a walking pneumonia if asymptomatic. While this may not require any further treatment with antibiotics or anything, it certainly warrants attention and knowledge that it is present in case the patient does develop symptoms down the line. And this can also serve as a valuable baseline. If further imaging is needed, they can always look back and see if there's any interval change between the two exams, resolution or worsening of the infection. Here we have a 53-year-old female who presented to us asymptomatic for general screening. This image right here is showing the major arteries feeding the brain. This is the circle of Willis. The two big arteries on the left and right are the internal carotids coming up from the neck and then entering into the head. And then when they get in there, they create a circle connecting the anterior circulation, middle circulation, and posterior circulation. And here the red circle is highlighting a brain aneurysm. This one is coming off the anterior communicating artery. It measures around 4 millimeters. Now, these can be managed differently. Some need to be intervened on, and some can be safely surveilled. What's really important here is that we can provide the information, the size, the location, and then that needs to be assessed with the patient's medical risk factors, whether this needs to be intervened on or can be safely surveilled to look for any change. Here we have a 38-year-old female presented with no significant past medical history. This is an axial image of the pelvis. The red circle is laying over the left pelvic region, and you see a bright lesion within the circle. This is highlighting blood content within a cystic lesion within the left ovary, which would be consistent with an endometrioma in this case. Whether the patient has symptoms or not, this is valuable information to know about. Endometriosis is not an uncommon condition and affects quite a few women and can actually lead to just like chronic pain, discomfort, and even infertility from scarring. So this is valuable information to know for future. Here we have a patient who presented to us multiple times. This is just one example of the images that he's presented with here. And all these circles are highlighting the muscles, and they have an abnormal appearance. They're showing a lot of white signal within the muscle bulk, which is consistent with fatty atrophy, a chronic process that occurs. And it can be due to several etiologies. It could be due to injury, could be due to a neurologic problem. In this case, this patient has a known history of muscular dystrophy, a genetic disorder where the muscles progressively atrophy over time. And the value here is that we can compare over time to see if the muscle atrophy is progressing or not. And if the patient is on any therapies, that's helpful information to know whether the therapy is actually being effective or not. So here we have a 56-year-old male who presented to us with a history of elevated PSA, prostate-specific antigen, a blood test that screens the prostate for cancer and inflammation or enlargement. On the right, we have 3 images. The far right image is the axial T2 image that's showing the prostate. And what we see there, the yellow circle is highlighting a dark mass-like region within the peripheral zone, the right peripheral zone toward the apex. And on the left is our diffusion-weighted imaging of the prostate, showing corresponding abnormal restricted diffusion. So the combination of these 3 images shows findings suspicious for a clinically significant prostate cancer. What I would note is that our imaging, while we are doing focused imaging on the prostate, it does vary from a dedicated prostate MRI in the sense that we're not using any contrast. We don't use contrast in the screening setting, but we are using the driving sequences to detect abnormalities within the prostate. Here in the same patient, higher up in the abdomen, we're looking at 2 sets of images called in-phase and out-of-phase imaging, and this assesses for fat deposition within the organs. Here on the right side of the image, we see part of the patient's liver. And what we're seeing in the right image is a geographic area of dark signal dropout within the posterior aspect of the liver. And this is showing geographic fat deposition within the liver. We do like to know about this since fatty liver disease is often reversible just with diet and exercise. And if long-standing and progresses to more inflammation, it does damage the liver tissue and can predispose to liver cancers and chronic liver disease. Also on this set of images, we see another abnormality, which we can actually characterize with these 2 sets of images. On the left side, in the left adrenal gland, we see a nodule mass that's also showing dark signal dropout on the out-of-phase imaging. So what that tells us is that there's fat within the lesion in the adrenal gland, consistent with a benign lesion called an adenoma. So we can characterize it, whether it's benign or malignant on this exam. But what we cannot tell you is if it's hyperfunctional or not. That requires blood tests.
Thank you to Dr. London and Dr. Durand, and to all of you for joining in today. That takes us right to the end of our webinar. I hope it was helpful. Some of you might be partners of ours already in having patients come through. Some of you might have had a patient bring a Prenuvo report to you, and you're wondering what this is. Regardless, we hope this was quite helpful. We want to hear from you. You can, of course, give us a call anytime, or you can reach us directly at an inbox that we have tailored specifically for folks like you. You can contact us there at practitioners@prenuvo.com if you want to learn more about how these partnerships work and how you can give sort of special access and preferred rates really directly to your patients. So again, don't hesitate to reach out. Thank you for joining us today. It's been great, and we hope you join the upcoming webinars moving forward.